So I'm pleased to welcome Monica Laronda. Monica is Director of Research for the Fertility and Hormone Preservation and Restoration Program at the Ann-Robert Lurie Children's Hospital of Chicago. And she is also Assistant Professor in the Department of Pediatrics and Department of Obstetric and Gynecology at the Northwestern University. And the talk today will be about tissue cryopreservation in patients with difference in sex development. Thank you very much for being with us.
Thank you all so much for the invitation to speak about some of the interesting patient populations that we see in our clinic. And I want to start by saying this is a huge collaboration. I am the Director of Research for the Fertility Preservation Program, but I work with some amazing clinicians, that some of whom are here in the audience, you may have met yesterday, that might be able to answer or elaborate on some of these the clinical aspects of our patient populations. But what I hope to discuss with you today, and I've been asked to discuss, is some of these learning objectives. First, to understand some of the differences in sex development or the intersex patient populations that desire gonadal tissue cryopreservation. Describe how gonadal tissue cryopreservation procedures can be integrated into the standard care of DSD or intersex patients. Identify how our gonadal tissue cryopreservation, identify how your Oncofertility program may serve your DSD or intersex patients that you might see at your own institutions by offering gonadal tissue cryopreservation as one of our collaborators. And so I just want to start by giving an overview of what differences in sex development means as far as a patient population. It's an extremely diverse set of congenital conditions that are characterized by 3 categories. So the genitalia, that is typically atypical or incongruent with chromosomal sex, the sex chromosome aneuploidy, or disruption of sex hormone production or response to those hormones. There is approximately 1 in 2,000 to 1 to 4,500 individuals that have clinically identifiable traits of differences in sex development, or also we refer to them as intersex as well. And so one of the things that we like to refer to, one of the very seminal papers for understanding what might be within dysgenetic gonads or gonads from differences of sex development patients, is one of these papers from Courtney Finlayson, who's here today. She looked at germ cells by distinct age groups. So these reflect infancy, childhood, and adolescence. And you can see that there's significant decrease of germ cells as these individuals age. So about 44 patients with DSD and gonadectomy were examined. Their gonads were examined. Germ cells were present in about 68% of those patients, and the presence varied by diagnosis and age. So I'm just pointing out a few here. So you can see the XOXY Tanner syndrome, or 45X, 46XY mosaicism. You can see that there was a few number of germ cells, but germ cells were present even at 145 months. And then another example is this mixed gonadal dysgenesis, which had a significant amount of germ cells within that tissue at about 15 months. Again, this is a hugely diverse population, and so it's really challenging to identify, and we still have a lot of work to do in which we can look at this tissue at different ages with different diagnoses, understanding the genetic backgrounds on top of that, and figure out what we can do for these patients. But this was definitely a paradigm shift in our understanding, in that the DSD population actually does have, or potentially might have, some germ cells within their gonads. And so we did a survey as part of the PIN group. That is, one of the major draws for this Oncofertility Consortium is many of those committees that we've formed as part of it. So we did a look at some of the institutions that participated in the survey for cryopreservation for DSD. So 132 providers answered the survey. And making up 55 U.S. institutions. 47 of those were pediatric hospitals, and 5 international sites were also included in this survey. Many individual providers offer medically indicated gonadectomy for patients with DSD, and 41% of those offer cryopreservation. There is a variation in what some of these institutions offer, or what some of these providers offer, as far as taking a biopsy for pathology analysis, doing research on it, and some of them were not saved at all. There's also a very diverse group, again, of DSD conditions that I'll go into, but some of these institutions only were seeing some of these patient populations. So I'm going to talk a little bit about gonadal tissue cryopreservation at Lurie Children's. So we had several patients and families that came to us and really wanted to cryopreserve their gonadal tissue that was removed for a medically indicated reason, so prophylactically. And we had 6 DSD patients that saved their tissue under an exemption to OTC and TTC protocols that were existing within our institutions. So this was really in response to patients and families coming to us and really wanting to cryopreserve tissue. And we then thought about how are we going to integrate this into their normal primary care for their DSD. So we finally were able to get an IRB-approved research protocol in 2018. And our study aims are as follows: to evaluate and determine if viable gonadal tissue and germ cells are present, to attain research tissue, which is, of course, optional, to optimize some freeze-thaw techniques, to develop new technologies on how are we going to use these germ cells and these tissues in the future, and then really for a long-term patient follow-up, for timing, the type of hormones and tissue that they might want restored. So this is our protocol inclusion criteria. Individuals are less than 30 years of age and are diagnosed with a difference in sex development who has an increased risk of malignancy in their gonadal tissue. Again, this means that their gonads are being removed for another clinical indication. So this is not the primary indication, is to cryopreserve their tissue. And I think as you notice as I'm talking about this, I'm not saying fertility preservation, I'm saying we're cryopreserving their tissue that's coming out. So the traditional paradigm, and I think this is a little dated, but just to remind everyone, it was assumed that there was infertility with these DSD patients, and that their cancer risks were high, no matter which DSD they had. And so early gonadectomy was recommended, but then there was a paradigm shift with expanded knowledge about the possibility of fertility potential, a lot of times because of the germ cells found in those tissues or because patients were getting pregnant, especially those Turner's populations. And that their individualized cancer risk may be actually less than what we had originally thought as a group. So gonadectomy with multidisciplinary evaluation is extremely important, and there's a lot of shared decision-making. So our current protocol inclusion criteria, to just elaborate on this, is that there's a DSD condition with increased gonadal tumor risk and planned gonadectomy for their primary prophylactic medically reason. So these are the understood categories of high, intermediate, and low risk for gonadal tumors. You can see that these are divided by different diagnoses. And another key exclusion criteria for our protocol is that if they're unable to provide consent, if they're over the ages of 18, or assent, if they're from the ages of 12 to 17 years old. So if we're not able to get, informed consent from these individuals, this does not go through. So one of the papers that we published to describe some of our process and how we really tried to integrate the gonadal tissue cryopreservation within care came out in 2020 in the Journal of Urology, and I'm going to break down really what our shared decision-making protocols look like. And so you can see that there's a multidisciplinary clinical team that discusses the new incoming patient. This approximately takes 1 hour. The clinical appointment takes 2 to 3 hours, and this is with endocrinology, surgery, psychology, genetic counseling, and social work. Then there's a patient care plan that is discussed among the group for about 10 to 15 minutes per patient. And then there's the DSD fertility consultation with the patient and family that reviews all of this information with the family. So it's not a fast process. We intend it to be really slow and thorough. And then we have weeks to months with a discussion of psychological consults. That is, 3 by 1 hour sessions as needed. The fertility preservation team consults that describes to the patients and their families that this is extremely experimental. We are cryopreserving their tissue, but we might not know how it will be used in the future. They might have different germ cells than how they identify, and that there may not be a way to transplant that back, or they might not want to transplant this back. Again, this takes weeks to months. And then I'm going to expand a little bit more on this, but just as the first, primer indication of this, if there is tumor identified in the pathology results from our patients, they're having their prophylactic surgery, they're removing the gonad. We take some of that. We take half of that. And if the pathology department finds tumor within the half that pathology receives, that remaining tissue is recalled, and those findings are documented. So is there a presence of germ cells? Is there malignancy? And I'll get more into this detail with some examples. So the patient will then have a follow-up to discuss the pathology findings, and the family has ample time to discuss with their clinical team and amongst themselves whether or not they want to save that tissue long-term in storage. So right now it would be processed and within our clinical lab at Lurie. So this is before we send it off to ReproTech. We wait for the family to have this discussion, get all the pathology results back, and they can decide to transfer that tissue for long-term storage, discard the tissue, or donate the tissue to research. And this is, of course, recorded with a tissue disposition documentation. So this is what our patient breakdown looks like. We have patients, only a few of these patients per year, which I think can be expected. So again, we had our IRB protocol approved in 2018, and some of them, these are mostly partial androgen insensitivity syndrome patients that we think had, undescended testicular tissue that was very testicular, and so we sent it to UPMC and Kyle to do the normal tissue, testicular tissue cryopreservation. For gonadal tissue cryopreservation, I process that in the same way that we do the ovarian tissue cryopreservation, and I'll show a little bit more details about that. So they've mostly come from Lurie Children's Hospital patients. We've had 3 referrals. And then this is the different diagnoses that we have. So we have, Turner syndrome with Y, mixed gonadal dysgenesis, some unknown etiologies, but a 46XY that were atypical, complete androgen insensitivity syndrome, hypogonadism that was clearly testicular, PAIS, Swyer syndrome, Fraser syndrome, and additional mixed gonadal dysgenesis. and 1 ovotestis, which if you're interested in seeing that patient case was also published. So age at diagnosis for us, you can see kind of ranges from 1-year-old to up to 17 years old. And there was a variation in the number of years between diagnosis and gonadal tissue cryopreservation. And this really is due to both the urgency felt by either, with the shared decision-making between the families and their clinicians of how soon should that tissue be taken out, what type of risks are these patients and their families willing to take that this tissue might have a tumor and develop into a cancer. And you can see that, that will vary depending on that shared decision-making timeline. And then, of course, most of our DSD patients are within the Tanner 1 category, but this is the breakdown. This is also a breakdown of the procedures. Most of them, I think, because of the increased risk of developing a tumor or cancer or malignancy within their gonads, will have a bilateral gonadectomy, but some of them will have a gonadal biopsy or a unilateral gonadectomy, and then one was enrolled, and then during the operation, the procedure, there seemed to be no additional concerns, and so that tissue was kept in, and so we didn't freeze anything from that one patient. So there's a surprising number of the gonads that we had cryopreserved definitely had germ cells identified, and you can see that I've broken them down to the type of diagnosis that these patients had, but there's a little bit of crossing over. So you can see that Turner syndrome with a Y, there was at least one patient that had germ cells identified in those, but 4 other ones did not. Of course, this could be due to the age at which this was performed, because I did show as one of the first data points that their germ cells do seem to decrease with age within those gonads. And then when we then counsel the patients and families on whether or not they want to continue with the long-term storage of those gonadal tissue, those that did not have any germ cells identified still continued with the long-term storage. And one individual that had germ cells identified continued with the long-term storage. All of them had continued with the long-term storage. Sorry about this. And only one had it recalled to pathology. So the other thing that our pathologists will look at, of course, is there a malignancy present? And this is a little bit of a misnomer that I'm realizing now, but there are 5 patients with gonadoblastoma that is not necessarily considered a malignancy, but could be develop. About 60% of those gonadoblastomas are thought to develop into a dysgerminoma or another malignancy, so there was a concern. And then one patient did have a dysgerminoma. This patient was 17 years old with a complete gonadal dysgenesis. So this really should say, was there any tumor or concern, pathological concern present? And then I'm going to describe a little bit of this pathway in a little bit more detail with 2 case studies. But you can see that it's we've tried to really integrate this pathway or this process within the normal patient care. So in this paper, I'm going to give you 2 patient examples that really tested our workflow for identifying gonadoblastoma within the pathology tissue and how we responded to that. So you can see that we this is the setup of the normal gonadal tissue processing type lab that you've seen from many other people this morning. We do a cryopreservation. We process the tissue into the type of tissue volume that would enable the cryoprotectant to penetrate that tissue, and we keep everything. So we do not toss anything, and you can see that there's just variations in what this tissue is like. So we use the ethylene glycol plus sucrose slow freezing protocol. So we use the slow freezing cryopreservation method because we think this is the most appropriate for this type of gonad that we see histologically. And then if there's a recall by pathology examining that other half of the gonad that was sent, then we do this thaw, and we keep everything in the same order that we had laid out in the initial cryopreservation process. The pathologist is then able to kind of piece this back together and look for any borders for a better in-depth pathological evaluation, and look to see if there's a gonadoblastoma in one half. Is there a neoplasm? Would this affect the patient care in the other half? Sorry, a dysgerminoma or anything else in the other half. So for patient 1 was identified as a DSD individual from non-invasive prenatal testing with a Y, because by ultrasound there was female genitalia. So at birth, this individual is karyotyped and diagnosed, and then endocrine referred to oncology and recommended immediate gonadectomy because of their high risk of developing tumors from the gonads. Mom had actually read about fertility preservation and requested an appointment. These are the hormone panels for those of you who are interested. And then at 2 years and 4 months, a bilateral laparoscopic gonadectomy was performed. You can see the left gonad here and the right gonad here. We received half of that tissue, so half goes to pathology. We received the other half to cryopreserve. So this is the left half and a right half. The tissue was processed into 3 or 2 pieces and cryopreserved with the OC media. You can see that from the pathology report, there were germ cell neoplasia in situ, or gonadoblastoma was found in both the left and the right gonad. And so because of that, pathology was wanted to recall the tissue for better staging and to identify and clear borders. And so we thawed the tissue, and you can see there's also some fibrous tissue that we had kept intact with the gonad, but you can see that there's additional gonadoblastomas here. For the second patient, again, this was identified prenatally, and a karyotype was performed after birth. There was a uterus present, and the karyotype was 46XY. The diagnosis was complete gonadal dysgenesis, and again, you can see the hormone panels that were used up to 1 year and 5 months. And then at 1 year, 5 months, they elected to have a bilateral laparoscopic gonadectomy. You can see that the left gonad is here and the right gonad is here. You can see that there's this bulbous region that's slightly different than this other region. And so this was, again, half of the gonad was received in the lab and processed in a way that did not remove any tissue, but the whole thing was cryopreserved. The pathologist identified some germ cell neoplasia in situ or gonadoblastoma, especially in the right gonad. The cryopreserved tissue, again, was recalled for staging. and they evaluated both sides and did not find anything else. Both of those patients did not elect to save that cryopreserved tissue for long-term storage. There are also opportunities if other facilities are not able to cryopreserve their tissue on site in this way, that our program is happy to try to collaborate with those external sites to offer this for their DSD patients. So this would involve some regular phone calls, emails with external sites. And the approach would be a phone call with a clinician at Lurie, informational telemedicine with the family, and if gonadal tissue cryopreservation attempt was desired, they could travel to Lurie Children's for a consult before the surgery. So really working through that workflow that I showed early on with a lot of that time and real dedication and conversation with the family in a very collaborative way with Lurie. So the current state of accepting external specimens, we do not have anyone that is collaborating with us at this moment, but it's something that we haven't really advertised but are happy to take on. And then our lab and workflow is established, and we have this gonadal tissue processing suite to be able to do that, which I showed. This is a very busy slide, but it contains all of the details that we've thought through of how to initiate this process in a collaborative way with the facility that's taking out the gonad, and then working with the pathology either at that facility or within Lurie Children's to assess that tissue and to help make that decision for the patients if they want to continue to cryopreserve, save their cryopreserved tissue, toss it or donate that tissue to research, or if that will be recalled by pathology. Do I have a few more minutes? Or? Okay, I can end here. We have, this was just really a plug that we need a lot of ongoing research to understand what type of cells are within this tissue. So I'm primarily a researcher, so this is something that I deeply feel needs to happen in order for us to understand how are we going to use this tissue for the patients in the future, and this is just some examples of ways that we could do that. And I'll just end there. And I hope that I described our DSD or gonadal tissue cryopreservation process for our DSD or intersex patients was integrated in their standard of care, does not disrupt that, and was really a response from the patient families that were asking about this, and I hope that you think like we did, that we were doing this really thoughtfully with a multidisciplinary, very collaborative team. And because of that, I want to thank all of these people and the participants that have donated their tissue to research for us to continue this really important work. Thank you.
Thank you. Thank you very much for this very nice presentation about specific indication that really need further research, yeah. Certainly. Yes, there is one question.
Hi, Kyle.
Thanks, Monica. That was a thought-provoking discussion on a different kind of patient that we think about for fertility preservation. Like you, we will freeze tissues in this case, but only if the tissues are coming out for medically indicated reasons.
Absolutely.
And one of the things that happens frequently is the doctors will tell us that they don't know whether we're going to get an ovary or a testis out, or an ovotestis. And so in our place, we have two separate protocols, one for ovarian tissue and one for testicular tissue. So when it comes to consenting, this is a bit complicated. One, there's a possibility that you may get a gonad that's not congruent with the patient's gender identity. But the other one is that you may get both gonads or one opposite than what you expected, but the consenting all has to happen before you do the surgery. And so I'll tell you how we handle it, but I'm curious how you do too, and that is that if we don't know what's going to come out, first of all, we have to talk about the non-congruence and what do you want to do if the gonads aren't congruent. And the second thing is that if they want to save no matter what, we actually have to consent for 2 separate protocols, ovarian tissue and testicular tissue, because we don't know what we're going to get in the end.
That's exactly right. So this is actually what was a major motivation for developing a separate gonadal tissue cryopreservation protocol. In addition to that, we're just handling that tissue differently because we're working much more closely with pathology than we would for a normal OTC and TTC. And so our consents are really, it doesn't, of course we have the discussion that it might be non-congruent with their identity. Which is another reason why we have separate trans protocols as well. But for the DSD specifically, it doesn't matter. Like we'll unless we send it to you for TTC because we're certain that this is much more testicular and that happens with the PAIS patients especially. It doesn't matter. Like we will figure this out in our gonadal tissue processing suite as we're kind of going through the tissue or as we get feedback from the surgeons that took out the tissue. You can kind of tell by the texture, but we will consent them on this protocol because it just says gonad. It doesn't matter if it's more testis-like or ovarian-like. The other thing that we have done though is because we weren't sure if there was a testicular more tissue like that would have benefited from your specific expertise in TTC. We did, I believe, for one patient, consent on both the GTC and TTC protocol. So we have done that in the past, yeah. Thank you for your question.
All right. Thank you, Monica. That was very, very interesting. I have a question just from a more clinical perspective. What does this look like from a cost perspective for the patients? Like, I imagine the surgeries are covered because they're standard of care, yes. But especially in the patients where you have to do the processing before yes. you know, like if their tissue is recalled or their tissue does not have germ cells, are the patients still then paying for the processing even though you wouldn't be freezing them long term?
That's a great, yes. So there is a $1,000 charge for the processing in our facility, which is what I believe Kyle charges as well. I believe that's covered by insurance sometimes. Yes, Erin
in
says
Illinois,
yes.
I guess, because you're in
of
Illinois.
Course,
yeah.
in Illinois, yes. Mm-hmm. We are very fortunate to be in Illinois where these sorts of things are covered. We do not send it to Reprotech. Until we get the tissue disposition form from them. So we could have it for 6 months. We do not charge them for that storage.
Okay. So that would probably be like if you're thinking about taking on coordinating centers, that would probably be part of what we would have to consent is that you may pay for this expensive processing that then you cannot utilize. Is that?
Yes.
Okay.
Mm-hmm.
All right, great.
Yeah, the $1,000, yes.
So last very short question and answer.
I guess sort of more of a thought, because this was very thought-provoking. Thank you. My question was about complete androgen insensitivity syndrome, and many patients leaving their gonads in for much longer because it's low risk, but sort of the idea of maybe a unilateral gonadectomy and timing of that to potentially have some gametes and germ cells and keeping the other one in for puberty and hormones and all of those things. But
yes.
So more of a thought than a question, unless
yes.
you have any experience to share.
Well, so Courtney Finlayson is right behind you, and she might have some additional thoughts, but there were some procedures that you did see in our little pie chart where that was the case, the one unilateral gonadectomy, but go ahead.
Yeah, so I have to applaud Monica because she just gave a lot of clinical information, and if I had to talk about the lab and cryoprotectant, I would not do nearly that good of a job. But I can help out with this part of it. So our protocol right now, we would for complete androgen insensitivity, we would not be able to just remove one gonad. We may be able to offer that in the future. And what I'll just summarize for others who may not know exactly what we're talking about, but for individuals who have complete AIS, it used to be that it was recommended to have gonadectomy at the time of diagnosis, whether that was 2, 16, whatever it was. But there has been a shift in understanding that the gonadal tumor risk is very low, particularly in younger years. So it's probably more like having undescended testes. And so it's probably more like about 2%, at least in the first or second decade of life. And we don't know after that because nobody used to keep their gonads, so we don't know what we're going to say later. But those gonads allow for some endogenous pubertal development. So a lot of testosterone is made, it gets converted to estrogen. People can have their own breast development by retaining gonads. So that's sort of the new approach is for people to retain gonads. But then that brings up all these questions about, is there fertility potential? What could we, should we be saving any tissue at the time of gonadectomy? All of these things. But so right now, most of our patients, we wait till people are post-pubertal and then have a discussion, because then the individual can be making these decisions for themselves rather than having parents make these choices about their gonadal tissue. So it might be that in the future for this specific condition that one is removed, but I think that is more likely to be for some other conditions actually, even than for complete AIS. Just to note from that germ cell study, we saw germ cells in almost all of the patients who had complete AIS. They were squished and you had to look for them, but they were there. So we don't know what that means, but Veronica has more things to add.
I only want to add, so I'm Veronica Gomez-Olbo, I'm at the NIH. I actually have an androgen insensitivity study for natural history study, and our protocol for tissue freezing is called gonadal tissue freezing, and now I can do everything under one protocol, so just so you know, we also include these. But I only have a quick comment, because I think there's a lot of questions that we need to answer about these patients, and we really need to be doing the basic science research that Monica's doing. Like, we really should be taking a piece of this tissue and learning what's going on in there. We should not just be doing this and storing it, and then who knows? Maybe there's germ cells, but do they work? Maybe there's something that looks like gonadoblastoma. Is it even a gonadoblastoma? I've been talking a lot to pathologists, and they all disagree on what gonadoblastoma is. So my pitch at this meeting is we need more tissue research and basic science research. So thank you, Monica.
Thank you very much. So this is the end of the session about ovarian tissue cryopreservation. It's time for lunch. And just to remind you that if you need to charge your phone, there is a station behind. And see you this afternoon. Thank you very much to all.